So the waters, we call it a parietal acanthial projection because it's entering the parietal portion of the skull and exiting through the acanthion. So your positioning for the waters, this is for the 37 waters, is to extend the chin back far enough to just put the chin on the image receptor. So the nose will actually be elevated about a finger's width off of the image receptor. Your mentomeatal line should be perpendicular to the image receptor. So that's how you know that you've gone back far enough to drop the petrous ridges below the maxillary sinuses is once the mentomeatal line is perpendicular to the image receptor. So on your image, what you should see are you won't really see the petrous ridges all that well because they're so low, but you should be able to see the bottom or the apex of the maxillary sinuses. If you see anything going across the apex of the maxillary sinuses or anywhere in both but the maxillary sinuses, it's either because they have an air fluid level or you've missed position and their petrous ridges are inside of the maxillary sinuses. So enters the parietal bone, exits at the acanthion, therefore it is parietal acanthial projection. And I'll point out everything that we should be able to see on waters here in a minute. It shows everything. Rest the head, the head on the tip of the extended chin. Orbital-meatal line should form a 37-degree angle to the image receptor. Again, we've changed the relationship. Before it was the orbital-meatal line and the central ray. Now it's the orbital-meatal line and the image receptor. The mentomeatal line should be perpendicular, mid-sagittal plane perpendicular to the image receptor, and it should exit at the acanthion. And what you should see is good collimation on both sides. You should see the entire orbits and the facial bones. Shouldn't be any rotation or tilt. And how we're going to see that is distance between the lateral borders of the skull and the orbits on each side. And we talked about that whenever we first went over the Caldwell. We looked at the same thing. And the mid-sagittal plane of the head should be aligned with the long axis of the collimated field. That's basically so that the patient, the appearance of the skull isn't just rotated like that. And in as much as the difference between rotation this way, that's kind of like I don't know, the orientation of the head on a lateral of the skull. So it's just for uniformity. Petrous ridges should be immediately below the maxillary sinuses and trabecular detail and the surrounding soft tissues and all that. So this is what we should see. You'll see the frontal sinuses out here, even though it's not really what we're interested in seeing. That's what we're going to see is frontal sinuses. We got the orbits. The chin is back far enough that the petrous ridges, which are right here, are below the apex of the maxillary sinuses. You see the nasal septum. This guy's got a deviated nasal septum. So the reason I say this is one of the most important views of the skull is because of how much you can see. In my opinion, this should be one of the only views of the skull we should see. We can see the frontal sinuses, so we can determine whether or not the patient's got a frontal sinus infection. It's not ideal, but we see it. You see both maxillary sinuses, so you can tell whether or not they've got a maxillary sinus infection. You can see evidence of blowout fracture, which would be evidenced by fluid in one of the maxillary sinuses. The chances of somebody not having a sinus infection or not knowing they had a sinus infection, getting hit in the eye with a tennis ball, let's say, or a fist or whatever else, and then being diagnosed with a sinus infection in the same side that they took the hit in is really pretty rare. You're going to know most of the time if you got a sinus infection, or you're going to have pretty strong confidence that you might. The mandible is really pretty parallel with it's pretty horizontal here. If the patient had a fracture, you can see the lowermost portion of the jaw. It's not an ideal view of the jaw, but you can see the jaw, and you can probably diagnose whether or not the patient had a fracture across the body of the mandible. You can diagnose deviated nasal septum. You can also diagnose tripod fracture. Tripod fracture, you'd have a fracture here and down there, and the zygoma would be out and away from the rest of the orbit. You can also, and it's again not ideal, but you can see it, you can see zygomatic arch fractures. And what you're seeing in the zygomatic arch is this right here. One indicator that you have that you can look for to determine whether or not you've got proper extension of the chin is kind of like looking at the Scotty dog on the lumbar vertebra. Only this is an elephant. So you got a big ear right here, and it takes a lot to see this, even more so than the Scotty dog. You got a big ear here, you got a forehead, zygomatic arch is the trunk, and then it comes down to the rest of the stuff. It's really pretty insignificant. But you know, you got four legs, but really what you're looking at is the ear being the orbit, the forehead being the upper portion of the zygoma, zygomatic arch being the trunk. So, and you can also see the dens as well. All right. So reverse the waters, you're trying to accomplish the exact same thing. If your patient's on the backboard but they're out of the collar, then you can extend the chin and perform the exact same thing. So what you would do is extend the chin and put the orbital meatal line at a 37-degree angle to the plane of the image receptor. And how you would go about doing that is by extending the chin enough to where the mental meatal line is perpendicular to the image receptor, about like that. If the patient can't get their chin back that far, if they're on a backboard and they're in a collar, then what you can do is angle your central ray, put crosshairs right on the tip of the chin, and angle your central ray until it is parallel with the mental meatal line. So trauma situation, what you would do is not angle the patient's neck, not extend the neck, but to angle the central ray perpendicular to the mental meatal line, just like you were doing a fuse. So collimation and all that is really pretty much the same. The evaluation criteria is pretty much the same. Petrus ridges being below the maxillary sinuses without any kind of rotation. Again, rotations can be evidenced by looking at the orbits and their relationship to the lateral side of the skull. If the patient's rotated towards, then what you're going to have is the base of the skull, the posterior portion of the skull, and even the lateral skull. You're going to see more of that on the side that's elevated or furthest away from the image receptor. You can kind of see how, as I rotate the skull this way, the orbit on the side closest to the image receptor kind of extends out past the lateral side of the skull, as opposed to the posterior portion of the skull extends out past the orbit on the elevated side. So that's how you're going to evaluate your rotation. The extension of the chin, again, you're going to evaluate that by the position of the Petrus ridges in relationship to the maxillary sinuses. So reverse waters here. This patient looks like he's probably got a blowout fracture, possibly a sinus infection. You see this this maxillary sinus over here looks much more opacified than that one over there. Or more likely, since we don't see a dens here, that's an acrylic skull. And the guy just doesn't have any sinuses, probably filled up with acrylic whenever they filled him up. So Caldwell, this is the same Caldwell that we looked at before. So if a patient can sit upright, then that's fine. But if they can't, then do them on the table. And remember, the